Good evening, everyone. Welcome to the weekly huddle. Today we are on 108 session of weekly huddle. I am Dr. Praneeth. I'm a cardiologist working at the Kim's Hospital, Secunderabad. I am joined by my colleague and co-host, Dr. Anup Agarwal. We both are cardiologists working at Kim's Hospital, Secunderabad. And this program, we have been doing it for more than 2 years now. Most of you know about the program. This is an academic session where we bring out a clinical discussion. We talk about that clinical topic, knowing about some science, and basically discussing about the practical aspects of addressing that clinical problem. And today we brought one of those topics which we want to discuss. This topic is a bit sensitive, but it is equally clinically very important. And we thought that we should be discussing this thing. One of this important topic being about erectile dysfunction. Being sensitive, most of the patients feel a bit uncomfortable discussing this symptom with the physician, and most of them they do not pay attention to, but that is equally important in both social and mental well-being of a patient. And to discuss about this particular topic, I have invited a urologist, Dr. Priyank, who will help us in understanding about the nitty-gritties of erectile dysfunction. So I'll discuss the case which I have seen recently in my clinic, and I'll tell the relevant details about this patient, and we'll take opinions from each and everyone, and then we'll come back to Dr. Priyank for his expert opinion. So this patient is a 38-year-old male who is hypertensive and diabetic for about 5 years, and he recently had an anterval MI. We did primary angioplasty to left antidescending artery within a window period of 2 hours, and he did well. He has a residual LV dysfunction with an ejection fraction of about 45%, and he has completed his 3 months of follow-up. He is doing fine. He does not complain of any angina, and he is able to do regular day-to-day activities, and he is doing reasonably moderate level of activity where he is able to do 2 to 3 kilometers of brisk walking daily. And the pertinent medical history being he is on dual antiplatelet therapy, aspirin and clopidogrel. He is on high intensity statin, rosuvastatin 40 milligrams. He is on metoprolol 50 milligrams. He is on ramipril 5 milligrams a day. And he is also on eplerenone 25 milligrams. And he is on long-acting nitrate, that is mononitrate, isosorbide mononitrate, 30 milligrams once daily. And other medications for diabetes, which includes metformin and sitagliptin combination, and SGLT2 inhibitor dapagliflozin. His recent labs are all reasonably okay, and if there's any other significant labs that anybody wants to know, you can ask me, and I can provide you the details. So this visit, that is the 3-month visit post his primary angioplasty, in addition to the regular history that we took into, he complained on about erectile dysfunction. The questions that he essentially started with was about his apprehension on when to engage in sexual activities, and equally about his he noticing about his symptom of erectile dysfunction, which he brought to the notice. And this was the discussion that came up, and this is the discussion that I want to have in today's session. As a customary, I start with co-host Anup for his opinion. Anup is actually traveling. I don't know whether I can take his comments, but I'll try to see. Anup, if you are there, you share your comments on how do you approach these patients, and then we'll take it forward. I think Anup is not there, so because he's traveling, he is not available. We'll start sessions with opinions from other cardiologists and other physicians, and then we'll move to our expert guest who is there with us. So maybe I'll start with Prashant. Prashant, if you are available and if you could hear me, how do you manage this patient if he would have come to you in your clinic? Hello, Prashant, are you there? Maybe Prashant is not available. I'll ask Shankar sir to start with. Shankar sir is a senior physician who is a regular attendee for weekly huddle. Shankar sir, if this patient would have come to your OPD, how would you manage or evaluate erectile dysfunction? The questions which I have for you is, if a patient who has a recent coronary artery disease who underwent primary angioplasty right now in functional class 2 and on the medications, the question is, when can he resume physical activities after his recent acute coronary syndrome? And what he is complaining of is erectile dysfunction. How do we differentiate whether his erectile dysfunction is functional or organic? And if he has to give any treatment for his erectile dysfunction, both pharmacological and non-pharmacological, and in case if we have to refer to any specialist, then whom to refer and when to refer. So these are the questions that I have in my mind. What is your take on this patient, sir?
Good evening to all. First of all, I wish Dr. Anup and Dr. Praneeth all the best when they joined in the new hospital. Erectile dysfunction is a quite common problem we encounter in our clinical practice because I see many cases of diabetes. 50% of the diabetic patients, they will have erectile dysfunction, even if they disclose or not disclose, but there will be 50% the individuals. Actually, this erectile dysfunction is almost a sexual health tsunami in case of diabetics individuals. And this is quite prevalent. And when it is there in diabetes individuals, it is earliest marker of coronary artery disease. And this erectile dysfunction predates the onset of symptomatic cardiovascular disease by about 3 years. So before he develops cardiovascular disease, the erectile dysfunction will be there 3 years earlier. So this is, it is harbinger of coronary artery disease. So before I discuss about the case, then I, as a physician, I would like to give a glimpse of erectile dysfunction. The causes of erectile dysfunction, most of the times they may be psychogenic because of the lack of sexual arousability, performance anxiety, and a strained relationship with the partner, and over to psychiatric conditions like depression, schizophrenia. So these are the psychogenic conditions, and the organic conditions, the mainly they are vasculogenic, then hormonal or endocrinologic, and neurological causes. Drug-induced erectile dysfunction will be there, and other conditions like aging and systemic metabolic diseases. So amongst the vasculogenic, as I told, the endothelial dysfunction and penile arterial insufficiency, commonest cause for the erectile dysfunction. Then venous leakage. The other risk factors for the cardiovascular disease, atherosclerotic, mainly the atherosclerotic disease gives rise to penile arterial insufficiency, and the risk factors mostly we encounter are diabetes, those for the cardiovascular disease like diabetes, hypertension, dyslipidemia, smoking, tobacco and all. So the second, after the vasculogenic, Then we encounter the endocrine problems. Most of the times, the androgen deficiency may be associated with this erectile dysfunction. In the males, so there will be male hypogonadism, the hyperprolactinemia, then hyperthyroidism, adrenal insufficiency. All these conditions will give rise to this hormonal etiology for the erectile dysfunction. Then the neurological conditions like cortical lesions, spinal cord, peripheral neuropathy, Parkinson's disease, multiple sclerosis. These are all the pelvic surgery, trauma, and all come under the neurological causes for the erectile dysfunction. So other miscellaneous, there are hematological diseases like sickle cell disease, then chronic kidney disease, then heart failure and others. So organic causes mainly vasculogenic, drug-induced, neurological, hormonal or endocrine, then the psychogenic etiology. Having known about the etiology of this erectile dysfunction, how I approach in my clinic, whether it is a psychogenic or organic, we will elicit a history of what about the nocturnal penile tumescence or rigidity, or erections, nocturnal or early morning erections, looking at the erotic material like pornography, what will be is the response, whether any tumescence or erections are there or not. If they are normal, these erections and the nocturnal penile tumescence, there is one instrument will be there. This will be highlighted, I think, by Dr. Priyank. Nocturnal penile tumescence or rigidity will be measured by Rigiscan. So with that, if they are normal, then it is a psychogenic. If they are diminished or absent, it is organic. So this is mainly, we should differentiate whether it is psychogenic or organic. And if it is abrupt onset, mostly it correlates with the reversible causes like medications, psychogenic, trauma, and etc. If it is a gradual onset, this erectile dysfunction, it will correlate with the vascular or neurological causes. And if there is a spontaneous nocturnal or early morning erections present, then it indicates that there is intact neurological reflexes and there is a normal penile blood flow. If there is associated decreased libido, it indicates that mostly endocrinologic or sometimes psychogenic. So then we'll go for the neurological causes when we elicit some genital sensation, the bulbocavernous reflexes, the chemastric reflex, anal reflex, scrotal reflex. If they are present, the neurological causes can be ruled out. Then we go for any general genitalia examination. Peyronie's disease, probably Dr. Priyank will enlighten. Peyronie's disease, we see this deformity of the penis, a curved penis, or testicle atrophy, or any prostate examination in the prostate hypertrophy, secondary sexual characters, and all these things will be looked into when we examine when we go through the history physical examination. And the lab, most of the times we do fasting blood sugar, post-lunch blood sugar, and HbA1c to rule out the diabetes, because it's the commonest cause for the erectile dysfunction we come across in the clinical practice. Then lipid profile, the free and total testosterone. This is, if there is a low testosterone, we order for FSH and LH to rule out whether it is hypogonadism or hypergonadotrophic hypogonadism. so that whether it's the pituitary hypothalamic axis or the testicular failure, we'll find it out with that. And other investigation, this will be highlighted by urologist. The intracorporo cavernosal injection, ICI, will be given. The cavernosal stimulants like papaverine or alprostadil, that is a PGE E1, will be injected into the corpora cavernosa. Then, if the penile blood flow is present in the erection and as well as the rigidity is seen, that means this vascular system is okay. So it rules out the non-vascular causes of it rules out the non-vascular cause. It indicates the non-vascular causes if it is present. So, and one more study, that is a penile Doppler study, the penile blood flow study. With that, we can find out is there any cavernous venous leakage or atherosclerotic pudendal artery that will be known, and pudendal arteriography or penile angiography will be done, because this has been very much highlighted by Dr. N.N. Khanna from Delhi. He is well versed with this technology, especially penile Doppler study and the penile angiography. With this, after having diagnosed whether it is psychogenic or organic, and amongst the organic, whether it is vasculogenic or hormonal or neurological or any deformities, then having known about this, then the treatment part, we go for, if it is psychological, we go for counseling of psychosexual therapy or behavioral cognitive therapy. If it is organic, then if it is vasculogenic, then we give first we give phytoceuticals, the nutraceuticals like L-arginine or fenugreek seeds, methi seeds. So this can be given, and then along with that, the PDE5 inhibitors. This is the main stay of this treatment for erectile dysfunction, I know, as far as my concern. So sildenafil, tadalafil, vardenafil, and avanafil is also available in the market. The vardenafil, it has got less adverse events. The avanafil is still more superior. There's a faster onset of action. Within 15 minutes it acts, and sustained duration of erection with the low rates of hemodynamic side effects. And it's a suitable medication for patients with erectile dysfunction and comorbid cardiovascular diseases and who are on nitrates. Who are on nitrates. This patient is on nitrate. So avanafil can be given in this patient. So the PDE5 inhibitors, which I mentioned, can be given along with the testosterone for a short duration of action. But we should be careful in an elderly individuals regarding the prostate cancer, which is a contraindication. Then one more word about caution regarding these PDE5 inhibitors is patient on nitrates, we should be careful, and a patient on alpha blockers like prazosin, terrazosin, roxazocin, tamsulosin, silodosin. So these are alpha blockers we use in hypertension or benign prostatic enlargement. So there they are almost contraindicated because of hypotension and sometimes syncopal attacks along with this combination. So having known about this first line of therapy, this low dose daily use of PDE5, and SOS before intercourse. Then second line is if they are not satisfactory, 65% they respond. If they don't respond, we go for vacuum pump devices are there. Then penile injections of cavernosal stimulants like papaverine, alprostadil, then phentolamine. These can be given. Penile injections. Then urethral suppositories. These will be highlighted by urologists. Urethral suppository, actually, I suggest urethral suppositories. I ask them to keep the pellet in the urethral meatus and massage it, and so that it will be absorbed into the corpora cavernosa. And at the same time, I give 30 minutes before and intercourse this any of this PDE5, especially vardenafil or evenafil, we give, so that you will have a good erection and a successful intercourse. So this is regarding the second line therapy, and third line is if they are not responding to this medication and this intrapenile, intracavernosal injections and vacuum pump devices, and then we refer to andrologist or urologist, uroandrologist. Then for the penile implants, they are malleable and inflatable, are there, the penile processes. Then especially the cardiological point of view, there is a corrective or a reconstructive vascular surgery is there. If there is a pudendal artery, internal pudendal artery stenosis is there, then we go for stenting, or sometimes bypass grafting also will be done. So if there is a venous leak will be there, diagnosed by the penile Doppler study, then we'll go for open microsurgery and with embolization, so we can correct that venous leak. So the corrective and the reconstructive vascular surgery and penile implants and prosthetic surgery will be the third line. With this, only when do we suggest him to resume sexual activity? Here already 3 months elapsed, successful coronary revascularization occurred, and is a stable coronary artery disease. And if you controlled hypertension and diabetes and uncomplicated myocardial infarction, and if there is NYHA class 1 heart failure, then definitely he will be cleared to resume sexual activity, and he are also cleared to take PDE5 inhibitors, and especially avanafil, because the patient is on Imdur. We can suggest avanafil where there are no side effects like hemodynamic side effects are not there with the avanafil. Even patient can be on nitrates also. Regarding the metoprolol, you can see beta blockers amongst the drugs, beta blocker, thiazide diuretics, digoxin, spironolactone, and all these they do cause the erectile dysfunction. Metoprolol is, since it is a highly selective beta blocker, that can be continued, or in that place the bisoprolol can be given, or nebivolol can be given. But nebivolol is little coronary artery disease, we don't suggest. So instead of metoprolol, we can give bisoprolol, in this case Concor 5 can be given. These are my take-home messages regarding the erectile dysfunction and regarding the case. Thank you, one and all.
Thank you, sir, for that elaborate discussion on erectile dysfunction, from diagnosis to evaluation and treatment options, the various levels. Thank you for those comments. I'll take comments from other people as well before I go to Dr. Priyank. I have Dr. Vijay Reddy, sir. Sir, can I have your comments on the two things. Like one is about beta blockers and the nitrates. We all know that beta blockers have been attributed to promoting erectile dysfunction, and at the same time, beta blockers are cornerstone for a patient who has acute coronary syndrome. And for a patient for whom, if beta blocker is attributed to erectile dysfunction, how do we evaluate and how do we modify beta blocker? Question number one. And second thing about the usage of nitrates and this phosphodiesterase 5 inhibitors, that is sildenafil, etc., where both are kind of absolutely contraindicated when patients is on nitrate. So how do you address these two questions, sir?
Good evening, everybody. My take on this patient is having anterior MI post-primary PTCA, 3 months old. He's on beta blocker, ACE inhibitors, and MRA. Most of the cases of erectile dysfunction in case of CAD is psychogenic. Though beta blockers are known to cause EDS, it is highly overemphasized. The incidence is very, very low. And other drugs like diuretics and this MRA also, they can cause, but the drug-induced erectile dysfunction is highly, especially beta blockers, it is highly overrated. So the life-saving drug, evidence-based medicine, we cannot stop beta blockers, and preferably we can give this bisoprolol, which also improves the endothelial dysfunction when compared to other beta blockers. That is a more useful beta blocker. And regarding the other aspects, with this patient already has crossed the acute phase, he can resume. I don't think we can continue with as long as patient is asymptomatic. We can withdraw the nitrates and start on evidence-based drugs, and we can give that phosphodiesterase inhibitors. Thank you.
Thank you, sir. So I'll come to Dr. Priyank. I have a lot of questions that I have to clarify from you. Thank you for joining Huddle. Dr. Priyank is consultant andrologist and urologist, and he did a fellowship in men's health and infertility from Singapore, currently practicing in Apollo. Thank you for joining, sir. My questions to you is about this patient. If he comes to clinic, then how do we actually diagnose whether these patients who are having erectile dysfunction, whether it is functional or organic? How do you evaluate so that we can move further, sir?
Yeah. So first of all, I'm very thankful for inviting me to this meet. So basically, as I've seen the case, so in order to diagnose any case, like first of all, the history, the age of the patient, and the associated comorbidities are very important. If the same patient of a very old age comes to me, definitely I will consider a psychological plus a hormonal imbalance as one of the initial diagnosis, along with drug induced. May or may not be, depending upon the dosage of the beta blocker, whatever he's taking. If a young age patient or a middle aged patient comes to me, initially I will do a hormonal workup. I will see whether the hormones are fine or not. I'll even take a detailed history regarding the smoking or any other comorbidities. Associated with that, if required, on an initial phase, I may even do a penile Doppler if required. I normally do not order a penile Doppler on a first visit because it's a painful procedure. Like we need to inject piperine into the penis, and then we need to see the systemic velocity of the blood within the penile arteries. So it's quite, and also it's associated with some complication like priapism. So penile Doppler studies definitely is a choice for diagnosis, but I think initial phase of drug induced can be managed maybe by changing the drugs if possible, or not. Such patients of middle age patients, I can definitely give them nitrates of a very low dose. Like normally for such patients, I prefer giving tadalafil of 2.5 mg, which is available in the market very easily. You can give very low dose, which helps in improving the endothelial lining has been proved by many studies. We can also add certain antioxidants, as you know, one of the sir has also pointed out regarding nutraceuticals like giving L-arginine. Even there are certain products like honey wheat, goat wheat extracts. All those things in combination, maybe for the initial month, I will be very aggressive in looking into how much improvement is there. If improvement is not there, then on the first line, I will do a penile Doppler study. I will see really exactly where the problem is, whether it is the endothelial lining, whether it is the arterial flow or the plug, which is leading to erectile dysfunction. If all reports appears to be clear, if everything appears to be clear, then definitely I'll go to the second part, where even if I give medical management, if the patient is not improving, then I may even go for the second line of treatment like vacuum devices. But all depends upon the age of the patient, and also I'll see the background, like what exactly the need is.
Sir, there is an index for erectile function. There is an
Yes,
international index for
IIEF
erectile-
score. Yes.
Do we
Yes,
use
sir.
it frequently, and how sensitive is it in diagnosing erectile dysfunction?
Normally I have changed, because IIEF is a very long list of questionnaire. Now we have changed into a better scoring called hardness score, in which we have 4 cylinders in front of the patient, and we tell them to touch the cylinder and let us know at what level of hardness do they have on erection. So that is called hardness score. We rate it from 1, 2, 3, and 4, which is very easy. And it in quick time we can know where exactly the patient is, whether he is into a mild, moderate, or severe.
Okay, sir. And regarding the drugs, like for a patient who has coronary artery disease, when we put them on beta blockers and nitrates, how much do
Yeah.
you look into these things, or how much do you modify or you discuss with a cardiologist before you suggest these drugs, sir? Or what would you recommend from a urologist point of view, suggesting a cardiologist about these modifications?
From cardiologist, definitely I will.
Sir, we are not able to hear you properly, sir.
One thing. Can you hear me?
I think there seems to be network issue at your end. We are not able to hear you properly. Your voice is a bit broken.
Just can you hear me, sir?
Not yet, sir. Still not clear.
2 minutes, sir. 2 minutes. Can you hear right now?
Yeah, now you are better, sir.
Yeah. So, sir, see, normally, a patient, if a cardiologist, when it refers to me, definitely I will take a detailed history. Like it will be a.
Sir, we lost you again. Okay, while Dr. Priyank is joining, I'll in the meantime go through the comments in the chat box.
Hello.
Hello?
Hello.
Yes, sir.
Yeah,
Where
I'm there. I think
Yeah.
something went wrong.
Right.
Yeah. So along with the cardiology as a teamwork, we'll definitely try to change the drugs or lower the dose if possible. If not, in that case, basically beta blocker and nitrates, to some extent, if we give a 5 PD5 inhibitors to a lower dose like a 2.5 mg, is not going to change the hemodynamics much. So I will put the patient on 2.5 mg, see the things it is. That will be a daily dose. 2.5 mg is a very small dose, which he can take on an alternate day also, or a daily day, depending upon the hemodynamic stability. Plus, I will be adding an L-arginine sachet along with it.
Okay. And how is this L-arginine available, sir, in the market?
So very easily available.
Okay. Okay. So there are few questions in the chat box. I'll try to take those questions, and then I'll come to my questions as well. So first thing,
Okay. Sir, can I join again in next 10 minutes? Is it possible?
Yes, you can join in. In the meantime, I'll continue.
Okay. Just give me a break of time. Yeah.
Sure,
Okay.
sure.
Okay, sir. Fine.
So there are few comments. Firstly, Anup says research would indicate that people who engage in sexual activity after MI or other cardiovascular ailments, once acute phase is over, tend to have higher longevity than those who don't. Uh, I'm not aware of this research. Probably we have to look it as an aspect of an exercise where sexual activity is also probably considered as a moderate level of activity, and probably the advantage is coming from that end. Beta blockers and thiazide diuretics are notorious to cause ED. We should aim to reduce or stop beta blockers once it is no more essential for clinical management. Thiazide drugs can mostly be stopped in routine cases. So the regular indication of beta blocker is for a patient who has an ongoing angina, or if he has an non-revascularized territory, or if the patient who has residual LV dysfunction where ejection fraction is 50% or less, versus most of the patients who have recovered from the acute MI. After 1 year of acute MI, if their LV function has improved, then beta blockers have no role. And then probably we can wean and stop beta blockers, which can probably help recover from their ED. Most of the erectile dysfunction because of beta blockers is reversible. And if it is really attributed, then probably beta blockers, after stopping beta blockers, the erectile dysfunction should probably go away. One question is, if PD inhibitors are to be given in patients with known stable cardiac condition, is short-acting preparation preferred? Sildenafil versus long-acting drugs like tadalafil. I think Dr. Priyank was suggesting giving a low dose of tadalafil. I think we'll get this question clarified. If anyone has a answer to this, can probably share. And smoking cessation is a good intervention. Not only it helps in preventing future cardiovascular event, it will also help with erectile dysfunction. Point valid, the index patient does not smoke, but all those patients who do smoke, probably smoking cessation should be strongly recommended, which has been attributed to erectile dysfunction. And then other comment is watch for drugs which have nitrates in it, like isolazine. Isolazine is again commonly prescribed for heart failure patients for afterload reduction, which contains isosorbate dinitrate and hydralazine, both being potent arterial and venodilator. I think that point is valid. And the usage of both nitrates and phosphodiesterase inhibitors is contraindicated, or caution should be exercised when this has to be prescribed. So this point is definitely valid. Santosh asks, since MI is a major cardiovascular event, how often one should look for atherosclerotic cause of ED before attributing it to drugs? There is mortality benefit of beta blocker in MI cases. DA say to look for internal pudendal artery block. Some studies show DEB to this artery relieves ED. So, Santosh, I think erectile dysfunction, there are multiple causes, and as you attributed, atherosclerosis being one of the important causes, being smoking, diabetes, hypertension, and all, ASCVD equally contributing to ED. Mortality benefit of beta blocker is definitely there. So, I don't advise stopping or reducing the dose of beta blocker unless there is a significant need to reduce the dose of reducing beta blocker, because as you said, beta blocker does save lives, so it should not be stopped at any cost. Versus if the need is important, then there is a calculated risk that I believe should be taken. Regarding evaluation of atherosclerosis or obstruction to the internal pudendal artery, this I'm not sure. And if that is the reason attributing or causing erectile dysfunction, then probably revascularizing that vessel, both by percutaneous or by surgical revascularization, should probably do. But this I'm not aware, which I will again would be eager to know from the audience. Question from Anup: in patients with non-revascularized coronary artery disease, any role of doing TMT before clearing for intercourse? I don't know. Vijay Reddy sir, what do you think? Should patients be routinely asked for a treadmill before we advise them to engage in sexual activity?
No. no need for TMT because it's a stable CAD. We can allow him. No need for any treadmill test. That is my feeling.
Okay, sir. Point noted. I think clinical decision should suffice, and there is no objective need to do the physical stress testing. Probably assessment by a clinician should suffice. Durga Kalyani asked, I came across one patient, age 45 years. He's a hypertensive on Telma 40 and hypothyroid and 75. He's smoker and occasionally alcoholic. He has taken sildenafil 100 milligrams and he slept, and in the sleep he died. He didn't perform sex before death. What is the safe dose, and without sexual performance will it happen death? What is the safe and worst dose of sildenafil? I believe Anup tried to answer this question. Standard dosing for sildenafil will be 25 milligrams. Even 12.5 is tried with reasonable benefit. Doses can be escalated as per response, but definitely giving 100 milligram as first dose is not advisable in my opinion. So the main mechanism of action of sildenafil is vasodilatation and common side effect being hypotension, which can be aggravated if the patient has concomitant antihypertensives which he is using, like telmisartan or other drugs. So did sildenafil aggravate hypotension in this patient? Probably. So, and taking a reasonably higher dose of sildenafil, which is 100 milligrams, probably as a first dose, presumably this is the first dose that he was taking, which could have led to a profound hypotension and could be one of the reasons for his death. And regarding the safe dose, it is always better to start low, and then depending on the requirement, the doses can be escalated. But always being mindful of the possible interactions with other drugs and profound hypotension. Refractory hypotension is probably one of the important reasons that needs to be paid attention to whenever these drugs are being prescribed. Santosh writes about PA and PI study. Patients not response to phosphodiesterase inhibitors have focal internal pudendal artery stenosis in severe CAD and ED cases. Please share your experiences looking for treatable atherosclerotic causes. Point valid, but should this be routine evaluation for patients with ED? I'm not sure, because as Vijay Reddy sir was saying, majority of the patients of erectile dysfunction are psychological, and there are several causes which can contribute to it. And definitely, if this is one reversible reasons or treatable causes of ED, I think this should be looked into it. But I have no experience. If anyone has experience, maybe if Dr. Priyank can show some light on his experience, whether he could treat these patients, I don't know. And Archana asks about, what about the newer beta blockers like nebivolol, and what about tadalafil? So nebivolol is said to be one of the beta blockers which is said to have improves endothelial function. Nebivolol is actually a racemic mixture of both D and L enantiomers. L-nebivolol is said to be responsible for vasodilatation because of the endothelial release of nitric oxide, and the D-nebivolol is said to be having the beta blocker activity, and this is one of those beta blockers which is said to be lesser attributed to erectile dysfunction. So probably this should be preferred beta blocker in a patient with nebivolol, but my experience is limited, and how much can science back up is also not very clear. But there are few case studies which show that in comparison to metoprolol, nebivolol is said to be having better improvement in erectile dysfunction based on this international index of erectile function. This is the knowledge that I have. If anybody has a personal experience of using nebivolol and improving in erectile dysfunction, can probably share. I think Dr. Priyank hasn't joined yet. In the meantime, I will take questions from other attendees as well. Santosh, you did ask a few questions, but if this patient were to come to your OPD, what would you make changes? Would you change his dosage on beta blocker, and would you change his nitrate, and would you recommend using SOS basis phosphodiesterase inhibitors?
Sir, I think I'll change the beta block first to the bisoprolol, and then you stop nitrates. Then you'll start with a low dose of sildenafil in him and just see the progress. If he responds well, then we can continue. We can attribute it to the beta blockers induce erectile dysfunction, and we can slowly take off the sildenafil. If he doesn't respond to these changes and even to the PD inhibitors or sildenafil with incremental dose as well, then I'll try to look for organic causes. That means atherosclerotic causes of erectile dysfunction. So I think, sir, there are some studies which shows that intervention to the internal pudendal artery has definitely improved the sexual performance. So I think we need to look for these causes because diabetic and one major atherosclerotic event. So there is possible atherosclerosis in this artery as well. So I don't know, sir, what is the exact modality to look for, whether CTI angiogram or to look for invasive, DSA, or look for use any ultrasound, duplex ultrasound to look for these causes. And I think that there is one more veno-occlusive cause of this thing, erectile dysfunction in diabetics. I don't know how to go about these cases. And that's all, sir, I have to say.
Yeah, thank you, Santosh. So this patient whom I've seen, his diabetes, at least because of the change of medication, his diabetes well controlled. His A1C is 7 now. Lipid profile is within control. Thyroid profile I checked, which was normal, and I did not do any other hormonal study for him. And all the other parameters seem to be satisfactory within my range. And as in my opinion, most of the reasons for erectile dysfunction are again psychological. I go with what Dr. Vijay Reddy has said, and I kind of counsel the patient about the same thing. I could not have the confidence of stopping beta blockers, so I kind of switched over to from metoprolol to nebivolol, because I believe he should be on dosage of beta blockers, because sexual activity again increases sympathetic activity and can precipitate arrhythmias or can precipitate angina and failure. So I switched over from metoprolol to nebivolol. And I did not stop his nitrate because he still had some residual coronary artery disease. I advised him not to take any phosphodiesterase inhibitors because of the risk of hypotension. I tried to counsel him and warn him about the potential interaction. And I tried to reassure him that it could be psychological, and review after a month's time to see whether there is an improvement. And if it doesn't, then try to take steps further. Dr. Priyank has joined. Dr. Priyank, if this patient who I have seen, if we have to give him non-pharmacological measures because of the potential interaction of these phosphodiesterase inhibitors with the usage of nitrates, and if I'm not in a position to use, how effective they are, and what non-pharmacological measures can be offered to this patient?
Yeah. So, Dr. Praneeth, basically, see, as suppose if you have confirmed it, definitely is a drug induced, but mostly the drug induced ED will contribute only around 20 to 30%. More 70% part will be psychogenic. So, first, along with counseling, a very strong counseling is very important. Second thing, suppose if I'm not giving him phosphodiesterase inhibitors, then I will start him with L-arginine supplements, which are very effective. Second, in the market, we have something called pine bark extract. It is nothing but it's a substrate which will help in improving the nitric oxide production within the endothelial lining or reversing the endothelial dysfunctioning. It is a very new in the market and it is giving very good results. So that is a pine bark extract, which I may add. Along, because of the psychogenic ED, I will always try to go into the detail of libido, whether the patient is having a good libido or not. If the libido is down, then I may even add certain things like horny goat feet extract and even ashwagandha. That is one of the fantastic Indian weed which has been always underrated. Ashwagandha not only helps in improving his what we tell the libido, the mental status, but I think it gives a very well overall health effect which improves multi-organ dysfunctionality. Okay. So these are certain nutraceuticals which I'm using in my practice, and definitely along with a very good counseling, they are giving very good results in the initial part. Some of them also, if I do a penile Doppler and if I see an arterial insufficiency in that, we have a very new thing in the market called low shockwave therapy. You might have heard about it, a low shockwave therapy. A low shockwave therapy can also be given to the patient, though he's on antiplatelets, because it is not going to give any. We are giving a shockwave of only hardly of 0.9 hertz with a less than a joule. This kind of treatment, along with nutraceutical therapies, can be tried in the initial phase once the patient is stabilized and the patient cannot be refrained from nitrates or we cannot decrease the beta blocker dosages. So this is the first line part. In the older age patients, many times they are not ready for all these kind of things. So in those cases, vacuum device, as one of our doctors have given a list of first line, second line, and third line treatment what we are offering, vacuum device is a very good option, but this will work only mainly in the old age patients where along with arterial insufficiency, there is veno-occlusive disorder also. Last and the least, once the things are all stabilized, patient don't want to take, because we see a lot of patients coming up to the clinics and they are fed up with the medications what they are taken already. From the cardiac side, they are taking 10 medications. Again, if I add more 4 medications, definitely he's not going to take any of them. So I hope this scenario will be common in your OPDs also. So in such patients, we try to counsel this patient for more of towards maybe implants or vacuum devices. One of our friends also told me regarding this pudendal artery bypass and all those things. Said basically this kind of surgeries are time consuming and also not much rewarding. They are financially more costly and also they are not much more rewarding, because the penile artery, which is of a very smaller diameter, cannot be just revived, because there is an endothelial lining problem. There is not a much problem regarding the plaque problem. So that is more of a problem rather than, so we should focus more on local issues rather than going for a bypass, because initially many of them have tried going for a pudendal bypass and all, but they are not much successful. Even in today's era, most of them we are not even practicing. Most of our andrologists, we are not even encouraging those things. So in a very nutshell, I think till the patient stabilizes, nutraceuticals are good. Once he stabilizes, once we can reduce the dose of nitrates, beta blockers, we can add a very low dose of PDE5 inhibitors. And if the patient is not ready for anything, vacuum devices, implants are the choice.
Sir, one
Back to you,
practical
Pranit.
concern which you said about this usage of nutraceuticals, which we
Yeah.
commonly do not prescribe and or do not have the knowledge of it. Practically, how do we prescribe and the potential interactions with the other drugs, just like what we use the phosphodiesterase esterase inhibitors? Do we equally can expect the same side effects associated with them?
No, sir. See, L-arginine is the only substrate through which nitric oxide is being formed. You are not blocking any of the enzyme, sir. You are only increasing the substrate. You're not inhibiting any enzyme. So it is the phosphodiesterase inhibitor will inhibit the enzyme, which is leading to this kind of thing, sir.
And how
So
do we prescribe,
L-arginine,
sir?
sir,
Like
in market we get L-arginine in n number of names. Like we get Erectex powder, we get what we tell Himrec Pro powder. All this powder I tell them to take to mix it with warm water and drink in the morning after breakfast.
Dosage, sir? Any particular
Sir,
dosage?
it's a specific, sir, it's a specific packet per sachet. It is always in a sachet form. So whole
Okay.
sachet has to be taken daily, because different pharmaceuticals will put this powder in a different pharmaceutical. Like some people will give 3,000 mg of L-arginine, some are giving 5,000, some are giving fenugreek along with that. So they have fixed it like a sachet is normally taken, is given to a person of around 70 kgs or 60, like normal moderate build human being, like Indian population can take one sachet per day.
And is this for a regular dosage
Yes,
kind of
sir.
thing, or is
Regular,
it before the?
daily. No, sir. Daily. He has
It's
to
a
take it
daily
daily.
thing. Okay.
Yes, daily, because it is going to replenish your stores, sir.
And normally, after we take this L-arginine, after how long can we expect the response to the treatment, sir?
Normally,
On an average.
50 days, on an average, around 30%, 50%. Some may even see in a week, because it all depends upon how much depletion your body has for L-arginine.
Okay. You
Very,
also
very
mentioned
nicely,
about.
if the body is taking up it very nicely.
Yes, sir. You also mentioned about pine bark extract, if I heard you correctly. Pine
Yes.
bark extract
Yes.
and
Sir.
ashwagandha. And how do we prescribe these things, sir?
Sir, we get in a pre-launch it's a US medicine.
Sir, I'm sorry, we are still not able to hear you again. Sir. Hello.
Now, sir, I'm able.
Your voice is still breaking. So it's like.
Hello. Sir, is it fine?
No,
Hello?
sir. It is still.
Just give me a second, sir. Just give me a second. I'll go in the network part.
Sure.
Just a minute.
Sure, sir. Thank you. Yeah. In the meantime, in the chat box, Anup asks whether there is any concern for using nebivolol in cardiac patients for its potential sympathomimetic activities. I am
Sir,
completely.
can you hear me?
Yes, I can.
Can you hear me, sir?
You. We can hear you, Priyank.
Okay. So pine bark extract, sir, it is nothing but it's a product which will help in increasing the L-arginine and also improving the endothelial lining.
Okay.
Okay. So it's a new product. It's a US FDA approved product which we are using from last 6 months, and good results are being seen, sir.
And how do we? How is it available, and how do we prescribe this, sir?
Sir, it is available in a tablet form called Prelox. This tablet I give morning once, evening once after food.
Okay.
And regarding ashwagandha, sir, I think ashwagandha is an Indian, हम जो बोलते हैं ना जड़ी बूटी, Indian जड़ी बूटी. It's definitely it's really a fantastic weed which has a overall, like it's a holistic health approach which can give, even though if the patient is not having erectile dysfunction, also it will help increasing the mental stress, even decreasing the endothelial dysfunctioning, and in turn will help in increasing the libido also.
Don't we be in trouble in prescribing these drugs from the medical legal aspect of these things, Dr. Priyank?
Nothing pharmaceutical can be taken for also. So it is not like we have to be prescribed by a specific doctor or anyone. It's a OTC drugs. So nutraceuticals are OTC.
Okay.
So yeah, so there is not a problem in anyone giving it. That is not a problem. It is an OTC drugs.
And how frequently do you in your practice do you need to do these surgeries, sir, like penile implants or penile plumps, etc.?
Sir, penile implants I do very regularly. It's because I told you previously also, many of the patients, they are already burdened with lot of medications, and though they want to have a very good sexual life, in that case, penile implant, they opt for penile implant upfrontly in that case.
Because I'm glad that you mentioned about the drugs when you said you have to prescribe 4 drugs to improve the
Yes.
your sexual activity. What we
Yes.
fear is that patients may stop the cardiac medicines in need of this thing,
Yeah.
which we fear the
Yes,
most.
sir. That is the only issue.
The patient preference is something which is different and which we have to take
Yes.
into consideration. And Dr. Shankar
Yes,
was
sir.
mentioning about urethral suppositories and injections. How frequently do we advise these things, and how effective are these drugs, these therapies?
Sir, one of the doctor have prescribed intraurethral suppositories, if I'm not wrong.
Yes,
He
yes.
was mentioning about intraurethral suppository. Sir, in India, intraurethral suppositories are not available. They are prostaglandin suppositories, which are not available in India right now, sir. Alprostadil, we tell it as alprostadil. Alprostadil is not available in India right now because it is not been approved by the drug authorities of India. So it is not available in India right now. Outside in Singapore, everywhere where I was there, they used to give intraurethral alprostadil gel was there, which they used to introduce inside, and that is give a very quick response, and it is also safe, prostaglandins.
One question which Dr. Anup asked was about usage of short-acting versus long-acting phosphodiesterase inhibitors. What is your
Yeah.
take on this, sir? Which is a preferred thing? Like sildenafil is preferred being short-acting, or tadalafil being relatively
Sir, it
long-acting?
all depends upon the profile of the patient. I will again say, profile of the patient. Sildenafil, though it is short-acting, the complication rates are much more higher compared to tadalafil. Though tadalafil is 36 hours is the acting schedule, but the complication rates are less. Now the newer drugs are udinafil and vardenafil, which already sir has mentioned. They are much more safer, even quick acting, but they have a longer action. But the problem is, sir, complications are less. And second, the most important problem in this is finances. Today, udinafil, one tablet is costing 500 rupees, sir, which is definitely, we can't prescribe such expensive tablets to them. In the same way, tadalafil for 2.5 mg, 5 mg, hardly we get in 25 rupees or 20 rupees.
Okay. Yeah, so it is 8:06 now. I think we equally need to wrap up the session today. I will thank you so much for sharing your thoughts. Before I close, I will take comments from Dr. Somraju sir, and then we will wrap up. Somraju sir, your comments on the session and on the topic per se.
Good evening, Praneeth and everybody. And it was an extremely important area you brought up. And at the outset, I just wanted to mention one thing about when you have a doubt about a beta blocker possibly responsible, you either reduce the beta blocker and add ivabradine. You can give a combination sometimes. That does help. And secondly, in the introduction, you mentioned patients are uneasy and uncomfortable and bringing this topic of sexual activity. Actually, it's not patients, it is the doctors are even more uncomfortable in even raising these issues. That's the typical practice that we are all going through. The other issue is avoid polypharmacy. The drug interactions are very unpredictable. Even keep it in mind, even large doses of statins can also be responsible for sexual dysfunction. And avoid polypharmacy. That's what I wanted to mention.
Sir, how do you prescribe these phosphodiesterase inhibitors for a patient who is on nitrates? Or do we stop or do we use it with caution? Any
Number
tips
one,
and tricks? Yes, sir.
phosphodiesterase inhibitors, until now, we have no practice of prescribing them along with say nitrates. And we advise them against it as of now. Though the recently available drugs, there is some mention that they are safe. It's too early. And one of the issues mentioned is somebody took 100 milligrams of sildenafil and died. And mind you, two issues in such patients. The nocturnal dip in blood pressure after two sleep apneas, particularly aggravated. And also some of these patients are on alpha blockers and for prostate problems, and they take it at night. That will be a deadly combination. So as of now, to put it simply, on a personal level, I prescribe. I am not ready to prescribe nitrates plus these drugs together as of now. I am not yet ready for it. Thank you.
Yeah. Thank you so much, sir. It is close to 8:10, so I will wrap up the session. Thank you everyone for giving the valuable comments. I believe erectile dysfunction has multiple reasons to contribute, from psychological to organic. Diabetes, hypertension, aggravating atherosclerosis is contributing to erectile dysfunction. Most of them, if we do counsel the patients well, we can resolve the issue. And as Dr. Somraju sir was saying, doctors themselves hesitating in inquiring about the issue is definitely valid. I believe we should be more open to discuss these things, and if we can know the patient better, we can help them resolve this issue. Beta blocker dosage only if it is needed to be given, and if possible, reducing the dosage and taking other drugs in the form of ibuprofen is a valid suggestion. Nitrates, unless patient has an active angina, probably the dosage again to be reduced or to be stopped. Most of the patients can be given smaller doses of these phosphodiesterase inhibitors, making them understand the potential side effects, and looking at the other drugs which can potentially promote hypertension. And as I understand, tadalafil seems to be a safer alternative compared to sildenafil, though being considered to be longer acting, the side effect profile being less. So that seems to be a preferred drug. And there are new nutraceuticals available which seem to be improving without producing without producing more side effects, like L-arginine, pine bark extract, and other drugs. And when things don't fail, and or when the pharmaceuticals cannot be modified, then using non-pharmacological measures in the form of vacuum pumps, or lastly penile implants to help improve the performance. So I believe the spectrum of therapies are valid, and as I understand, the therapies are equally available to meeting a concern. Andrologist or urologist can help resolve the issue. And I think the most important thing is to know the patient better and what are his needs. And if majority can be treated with counseling alone, the problem can be solved. And limiting polypharmacy and giving them drugs on an SOS basis to meet to the demands of the patient is valid. Any final comments before I close the session? And if there are no more questions, I thank you everyone again for joining.
Dr. Shankar.
Yes, sir. Shankar, sir.
Only I would like to bring it to the notice of August audience regarding the recommendations regarding the sexual activity, resuming the sexual activity, and PDE5 recommendations. There is one good Princeton 3 consensus recommendations are there. You can go through that. With that, there is a description of the profiles are there, low, intermediate, and high profile, and where the recommendations are given. Princeton 3 consensus recommendations. Please go through.
Sure, sir. Thank you so much, sir. So with this, I'll close this session. So Weekly Huddle is hosted every Wednesday. The joining link is the same. All our sessions are recorded and we upload it on YouTube and podcast on a regular basis.
Dr. Praneeth, can I say
Yes,
something?
Sir. Yes, sir.
Thank you very much, and wish you all the best in the new organization. And your huddle now shows that you are getting sexier and sexier.
Thank you so much, sir. Thank you so much. With that comment, we'll close session. Thank you all for joining. Have a safe evening. Thank you.